getting to the right page. Well, good afternoon, everyone, and thank you for coming. I'm happy to be here with Minister of Health, Adriana LaGrange, and Alberta Medical Association President, Dr. Shelley Duggan, for an announcement more than a year in the making. 18 months ago, our government was elected on a promise to improve health care for every Albertan, no matter where they live in the province. And we've been hard at work on this commitment every day since then. Today, we're making a major step closer to delivering exactly on what we promised. Last year, Alberta's government entered into a memorandum of understanding with the Alberta Medical Association and committed to developing a new primary care physician compensation model. Since that time, we have heard from primary care doctors about their priorities. They want a pay model that recognizes the work they do to provide comprehensive care for patients indirectly, especially complex patients with chronic illness, as the current fee-for-service model doesn't reflect this. And they, of course, wanted a market and evidence-based payment model that will ensure family doctors in Alberta are compensated extremely competitively. Our government also identified priorities, notably maintaining high panel numbers, a minimum of 500 patients, which will incentivize panel growth and improve access to primary care for patients, providing after-hours care to relieve pressure on emergency departments and urgent care centres, and enhancing team-based care to encourage the developing of integrated teams that may include family physicians, nurse practitioners, registered nurses, dietitians, pharmacists, and other health professionals to provide patients with the best care possible. So I am pleased to announce that after working closely with our partners in the Alberta Medical Association, our government has developed a new compensation model for primary care physicians that delivers on these priorities. We are confident that this new model will help build healthier communities and dramatically improve our ability to recruit and to retain primary care physicians. At the start of this process, we recognized that Alberta physicians were struggling with administrative costs, burnout, and a health system that wasn't working for them. These challenges made it difficult to recruit new graduates and to retain the primary care physicians who are practicing in our communities. Recruitment and retention of family physicians is a nationwide challenge. And here in Alberta, we think a big part of the solution is fair compensation and incentives that make sense. Our new model will reward physicians who build up stable practices and see more patients. With this announcement, I think the risk of losing family physicians to more attractive jurisdiction is done. This new model will make Alberta an enticing and competitive place for doctors to come and to settle and to set up shop and to stay for good. And that's exactly what we're aiming for. When primary care is strong, the rest of our health system is strong too. And I do want to sincerely thank Minister Adriana LaGrange and the Alberta Medical Association for their very hard work and dedication throughout this process. Today's announcement is a major milestone in our efforts to give Albertans the high-quality health care that they deserve, and it's a great way to cap off a year full of progress on primary care in this province. The past year has seen us invest in recruiting more health providers and expanding the essential services that we're able to offer. We also piloted a new rural and remote bursary program for family medicine residents. And just last month, Primary Care Alberta became operational and has begun coordinating primary care healthcare services across the province. But of course, the work doesn't stop here. We look forward to sharing much more progress in 2025 as we continue the critical task that Albertans have entrusted us with. Thank you, and I'd now like to invite Minister Adriana LaGrange to share more details on the new compensation model.
Thank you, Premier, and thank you to Dr. Duggan for being here today and for your advocacy for physicians across this province. As Premier Smith mentioned, we are very pleased to be here today to announce that details on a new compensation model for family physicians has been finalized, following the framework established in April of this year. So finalizing this new model is part of our ongoing commitment to do everything possible to stabilize and improve primary care throughout Alberta. And we are confident that these changes will continue to strengthen the system, give family physicians the support they need, and ensure Albertans and their families are taken care of in their day-to-day health needs through every stage of life. This new model is unique. It's a blend between fee-for-service and elements of what is paid through other non-fee-for-service models. making it the first family physician compensation model of its kind in Alberta. It sets the stage and conditions for Alberta to be a national leader in the retention and recruitment of family physicians. But most importantly, as a market and evidence-based model, it recognizes and pays for the critically important work of physicians by considering the number of patients seen and the patient's complexity, as well as time spent providing direct and indirect care. That's why this model also includes various incentives, such as providing an additional 10% for time that physicians spend on administrative duties, as well as an incentive to encourage physicians to enhance team-based care. Additional incentives are also included for things like growing the number of patients on a physician's panel, for having a full-time practice, and for providing after-hours care, which is expected to relieve pressure on emergency departments and urgent care centres. There are also incentives relating to improving technology and adding efficiencies in clinical operations. In order to qualify for the new compensation model, physicians will be required to have a minimum of 500 patients on their panel. This is to encourage full-time practice, so more Albertans will have access to a family doctor. Through the new model, we estimate compensation will be competitive with similar models in both British Columbia, Manitoba, and as also in Nova Scotia as well. In addition, we are increasing rates for family physicians who are compensated through the Alternative Relationship Plan Compensation Model. It's called an ARP. So through an ARP, physicians are compensated for delivering specific services at defined facilities to a targeted patient population, or providing patient care as well as conducting research or teaching. Alternative Relationship Plans, or ARPs, rates for family physicians who work in hospitals were initially calculated in 2002. That's 22 years ago. While there have been increases that have occurred as part of ongoing agreements with the AMA, they are not competitive as they stand right now. So we have agreed to increase rates for family physicians who are in an ARP compensation arrangement, many of whom provide inpatient care in our acute care hospitals. So these family physicians are providing care both in the community to vulnerable populations and on hospital wards, and are critical to a fully functioning healthcare system. I think I speak for everyone here today when I say how excited I am about these changes and the positive effect they will have in the lives of Albertans and on the primary care system as a whole. We believe the new compensation model will relieve pressures in other areas of the health system. It will encourage comprehensive care in all phases of a patient's life, and it will give more Albertans timely access to the care they need. Family doctors will have an incentive to extend hours and attach more patients to their practice. New medical school graduates will see the model as a way to establish their careers in comprehensive primary care, and we expect the model will be a game changer in attracting family physicians from other provinces and countries. Enrollment in the compensation model will begin in January, with full implementation taking place in spring of 2025, provided we reach the minimum threshold of 500 doctors signing on to the model. Alberta's government recognizes that primary care is the foundation of the entire healthcare system, and these changes will give family physicians the supports they need. I want to thank each and every primary care physician for the critical work that you do each and every day. You are extremely valued, and we thank you for the exceptional work you do. I also want to express my thanks to Dr. Duggan and former President Dr. Parks and the AMA for their extensive collaboration with us to reach this important milestone. And it was truly a collaborative effort by all of us. I now would like to invite Dr. Duggan to say a few words.
Thank you, Minister. It's not often I have to lift the microphone up when I speak after someone else. So good afternoon. I am really happy to be here. What is being announced today will significantly, meaningfully, and positively impact our healthcare system for years to come. No matter where you look in the healthcare system, there are challenges. We share many of these with the other provinces and territories. Some are unique to Alberta, none are easy to solve. I appreciate that the Alberta Medical Association can continue to work with Alberta Health and the Minister as we face these issues. I thank the Minister and Premier Smith for their collaboration. Today in Alberta, lack of access to family and rural generalist physician care is a common denominator for many of the problems that we see. This includes bottlenecks, increased waits for care, and the care deficit that develops when people are unable to receive preventative screening, timely care, and treatment. Family medicine specialists fill a truly unique role. Their training and knowledge allow them to consider many different factors and treat their patients in a comprehensive way. The care that they deliver not only deals with physical issues, but also mental health and social factors. Thanks to what they know about the system, they can guide patients through all of these areas. Alberta's population is aging and growing rapidly. As we age, we tend to develop more healthcare needs and often experience multiple health issues that interact in complicated ways. These patients need more support, more time, and more attention. Our fee-for-service system has served us well since Medicare first began, but it is less and less able to support the kind of care that Albertans need. Today's announcement recognizes and invests in physician-led primary care, making it possible for these physicians to do what only they can do. The PCCM reflects their extensive training, experience, and leadership. It will also help ensure the financial viability of community clinics that are the foundation of our healthcare system. It is our hope that the model will help to restore Alberta as a destination of choice for physicians, residents, and medical students who want to practice comprehensive care. With the PCCM and new rates for the family medicine alternative relationship plans, primary care physicians have new compensation options. The PCCM is not designed to be a one-size-fits-all model, and physicians will, of course, need to consider what works best for them and their patients. But we are thrilled to see that we now have a new model that will support comprehensive, community-based family and rural medical care. I want to formally thank and recognize the physician leaders who have worked continuously over the past year with government to get us here today. They include members of the Section of Family Medicine, Section of Rural Medicine, Primary Care Network, Physician Leads Executive, and the ARP Working Group, along with some pretty amazing AMA staff. These individuals have devoted countless hours, reviewed data, drafted proposals, and hosted member engagement events. I hope and expect that the PCCM will make us competitive with our neighboring provinces and will encourage and support physicians to practice lifelong comprehensive primary care in Alberta. We believe this will benefit patients, physicians, and our entire healthcare system. Thank you.
Thank you. We'll now proceed to the media Q&A portion of this announcement. Please state your name and outlet before asking your question. We'll go with one question, one follow-up. First starting off here in the room, then going to the phones. First at the mic.
Hi, Tim Brooke with CTV. I have a question for you, Dr. Duggan. We heard a lot of broad statements there, but just maybe a little bit more specific for us. What kind of dent do you think that this new model is going to make as far as bringing in physicians, specifically family physicians? And what sort of problems are we still facing compared to other provinces, just unique to Alberta?
Yeah, I think that this is going to do a lot, not only to sustain and keep our family physicians that are here already, but will be attractive for people to come from other provinces and attractive for our learners to really think about doing comprehensive care. What's really good about this model is that, you know, fee-for-service only really pays you when you see that patient during that encounter. This new model is going to mean that the work you do behind the scenes as a physician, where you're, filling out forms for patients, talking to specialists, trying to get drug approvals, all of that is going to be compensated. That in itself, also there's going to be compensation when you're supervising, for instance, other medical team members. So this model doesn't pay for team members, but it reimburses the physician for doing all the sorts of things that a patient needs. That in itself may allow our physicians to take on more patients. So I think this is it's true benefit for Albertans, and I think it is going to go a long ways to making family medicine the foundation of our system. Do we have lots of problems? You bet we do, and I think that's across all the provinces. We have aging populations. We in particular have a care deficit left over from the pandemic. And so there's a lot to work on. I'm not sure there's a lot that is specific to Alberta. I think this new model is going to tackle that primary care issue, which was quite pertinent to Albertans.
Thank you. And Premier, I have one for you, off topic. Apologies. On the Green Line. Since the province continues to say that this is a city project, why are Calgarians not being presented with the costs associated here as something the city says is much bigger than the $6.2 billion your government has estimated?
The process that we went through was to rely on the City of Calgary to have all-in costs, because they were coming to us asking for us to increase our share. The number they gave us was $6.2 billion. So we made the assumption that was the all-in cost for the much smaller line that they were putting forward. We took that number and said, how much could we save by not doing the tunneling piece? The amount we'd save was $1.3 billion. And then we figured out how many stations we'd be able to extend that to in order to keep the all-in price at $6.2 billion. Since then, they've come back with additional costs that they didn't give us initially. So I would say that this is the problem that we've had with this project all along, is improper scoping, improper costing. Let's go down memory lane and remember that it was a $4.4 billion proposal for 40 kilometers, stretching all the way from 160th in the north, all the way to to Seton in the south. And so Calgarians are now seeing what the process looks like when you do a true costing, and it's looking like it will be more like $20 billion to build that entire line. So that's the conversation Calgarians have to have about whether they believe that $20 billion is worth it for this full project, whether they think having a portion of the project being built now as a bit of a down payment on what might happen in the future, or whether to scrap it altogether. That's really going to be up to Calgarians. But what we didn't appreciate was the constant escalation in the cost and the expectation that we were going to cost share on a project that was clearly poorly scoped. And so now we've got some clarity. We know what we're willing to put in, and it's going to be up to the city to decide if they want to go forward.
Thanks.
Hello, Laurence with Radio Canada. Minister LaGrange, some doctors family physician were asking to, drop the 500 patient cut to access the new compensation model. You decided to keep it. Can you explain a bit why?
Well, physicians always have the option to stay within the fee-for-service model. There is a blended cap option that they also have as well, although we've had very few physicians sign on to that blended cap that came out, I believe, in about 2017, 2018. So what we are looking to do is incentivize family doctors and rural generalists to actually practice comprehensive family medicine, which follows a patient throughout their whole journey. And we really feel to do that we want them to be working more full-time, taking on more patients. We have a deficit of roughly about 600,000 Albertans who do not have a family physician at this point in time or a primary care home, and we want to make that significantly better. And so we looked at that number and we settled on 500.
Thank you. My second question is a bit off topic as well. I'm sorry, and it's either for you or Premier. Alberta is considering creating a provincial body to oversight for medical assistance in dying, and a public engagement survey ends tomorrow. Why do you want to impose restriction regarding MAID, and why now?
What we're watching is that these decisions are ending up in court. If you look at the newspaper today, you'll see that there is a family that is challenging a decision that was made on medical assistance in dying on the grounds that they feel it was negligent to release an individual from a psychiatric ward knowing that he was suicidal. And so there's two options that you have. Do you just allow these cases to go through a very expensive court process, or do you develop some kind of internal tribunal panel so that we can make sure that we've got the proper checks and balances on that? I think that there's been 3 cases like this where families have challenged the process that we go through for confirming medical assistance in dying that would have appreciated some kind of intervention or ability to challenge the decisions being made by the doctor in question. And so it's because we're responding to what we're seeing in the courts to see if there's something more we need to do to create a separate process to include family.
Thank you.
Yeah.
Thank you. Seeing no more questions in the room, we'll go over to the phones. Operator, could you put through the first caller, please?
Yeah, your next question comes from Lisa Johnson of the Canadian Press. Your line is already open.
Hi, thanks for taking my question. This is for the Premier. We've been told by the Finance Ministry that they've received the Chief Actuary's report on the potential Canada Pension Plan withdrawal, but that it doesn't contain a bottom line estimate of Alberta's share. Are you expecting that estimate to be forthcoming? Has your finance minister been in touch with the federal government to clarify whether or not that estimate is actually coming from the feds?
Well, there's a bit of uncertainty right now about who the finance minister is and whether that will still be the same person after today. So, no, we haven't reached out to try to know what the next steps are in that. And once that gets some stability, we certainly will. We're a bit disappointed because we were under the impression that the chief actuary was hiring 3 different analysts to look at the legislation to be able to get 3 very precise ways of looking at this issue so that we had a precise number so that we could go out to Albertans and consult some more and see if they wanted a referendum. So as I understand it, doesn't contain a number and it doesn't even contain a formula for how you'd get to a number. So we will have to go back to the finance minister, whether it's the current one or whether it's a new one after today, and see how we might be able to get some certainty around that.
Thanks. And yeah, just a follow up. I mean, are we just going to continue the way to get that number, or do you have any actions that you're planning to take right now? I mean, are you going to take them to court to settle the question of the legal interpretation of the Canada Pension Plan Act, or will you bring this report as is to Albertans and perhaps revive the Jim Dinning panel?
Well, the report is available. It's a public document for anyone to see, and they'll be just as disappointed as we are that it doesn't include a formula or a number. So I don't think that the work that was commissioned was done, and so we'll have to see how we would be able to address that. We, of course, can't give any direction to the chief actuary. They report to the finance minister. So once things stabilize a bit in Ottawa, I'll be asking my finance minister to follow up and see what the next stage is. We actually both need to have an agreement on a number before going to a referendum. There'd be no point if we don't have some commitment from the federal government that they'll honor the result of a referendum because they dispute the number. Let's get the number settled so we know what the reduction in contributions would be, as well as the increase in benefits. And then we can see if Albertans want to go to a referendum. So I think we're still at stage 1, and it's disappointing because we were hoping to get we were actually hoping to get 3 numbers, and it seems we didn't even get 1. Sam?
And yeah, sorry. And thank you. And operator, can you put through our next caller, please?
Yes, your next question comes from Morgan Black of Global News. Your line is already open.
Hi, Premier. Ottawa is pushing its goal for a net zero electricity grid to 2050. As you know, in your joint statement, you said you were gratified. The change seems to be pretty in line with what your government wanted originally. Why still take Ottawa to court?
Well, if I passed policy in areas of federal jurisdiction, let's say I said, I'm going to start my own currency in Alberta in 2035. And they came back and said, you can't do that. That's Section 91 of the Constitution. That's federal jurisdiction. And then my response was, okay, well, don't worry. I'll do it in 2050 then. You don't solve the foundational problem. They have no right to tell us how to run our power grid. I'm glad that they're not going to be as punitive as they originally set out to. I'm glad Stephen Guilbeault has finally admitted what we have been arguing all along, that this is going to be, I'll tell you what he said. Some of the things that we put on the table were too stringent and from a technical point of view would be very hard to achieve without Canadians incurring a very high cost. So I guess the question is really for Stephen Guilbeault. Why, knowing that, has he drawn us through a year-long dispute publicly, in the media, in the courts, and through an advertising campaign when he full well knows that what he was proposing was unachievable and costly? And we're not done yet, because we've got two other idiotic policies that we're fighting, the proposed emissions cap and net zero cars by 2026. So I think he full well understands the implications of what he's doing. I think he's doing it to put a chill on investment, and that's why we continue the fight. They've got to just back off of provincial jurisdiction.
Thank you. And then for my follow-up, I wanted to talk about tariffs. I know you were in Ontario with all the other premiers. You said oil and gas exports are not going to be used as a bargaining chip, a little bit different than what Premier Ford had said. What tactics are you or the other premiers as a group exploring to mitigate or maybe get rid of the tariffs entirely, if not those?
I think that the premiers got aligned when we were together on earlier this week. It's been quite a change, and I think part of what we've had to do is that we've had to show leadership where we're seeing nothing but chaos from the federal government. And so I'm hoping once again with this cabinet appointment or cabinet shuffle that we'll stabilize and figure out who the lead is on trade negotiations. At the moment, it's a bit unclear. And in the meantime, it's up to us to reach out to each of our counterparts and make the case. And so the case that we're making is Canada shouldn't have tariffs on it at all. And so we're trying to all avoid January 20th imposition of tariffs. We want to recognize the legitimate concerns that are being raised about the border. We know these are legitimate concerns because we started our specialty sheriff's task units. When I first came in, we've got specialty units to shut down drug houses and do surveillance and do fugitive apprehension and now we're developing border security and fentanyl, which has been in the works for the last 18 months. And it's because we have a problem in Canada with guns and drugs and precursors and human trafficking coming across the American border. And we have to make sure that we're not causing the same problem to our neighbors. So we're doing this for Canadians' benefit. And I think it also should help us to avoid the U.S. president being able to invoke a national security provision as a pretext for bringing in tariffs. That's, I think, the connection that we're seeing here is that they do have the ability, and they've used it before, on aluminum and steel. They invoked a national security provision in order to be able to bring those in and go contrary to what our agreement is. So we want to make sure that we are taking away any of the excuses for them to say that there is a border security issue. And I was pleased to see that the federal government announced $1.3 billion towards that effort. We've already announced $29 million towards that effort. And then finally, we're just answering the questions one for one. I know that President-elect Trump tweeted out, no one's been able to explain why it is that we have a $100 billion trade deficit with Canada. Well, I can't explain that. It's because we sell them a lot of commodities. We sell them timber and oil and gas and food products and critical minerals. And as a result, when those prices fluctuate, our trade deficit goes up and our trade deficit goes down over time. But all of those products go into giving the Americans a subsidy with lower priced goods so that they can put it into their factories and their refineries and they can generate revenue and good jobs, not only for their people, but also lower prices for their consumers. So that's how I'm making the argument, is that we absolutely have a two-way street on this relationship. And I would go further than that. We buy more American goods than virtually anybody. We buy more than Germany, Italy, France, and the UK and Vietnam combined. We are one of the best destinations for those high-value American goods. And as a result, I don't think it's in the Americans' interest to disrupt that trade. So that's what I'm saying. I know that Premier Ford is saying much the same thing, and all of our provincial counterparts are making that case.
Thank you, Morgan. And we have time for a couple more questions. Operator, could you put through our next caller, please?
Your next question comes from Catherine Krakowski of Alberta Today. Your line is already open.
Yeah, thanks for taking my question. So this model was agreed to in April of this year, but it's not going to take effect until next spring. Can you explain what the difference is between implementing it now versus waiting until after the budget? What would be the difference?
What we agreed to in April was a framework, and then that had to go to rate review, and there were other processes that it had to go through. So what the next step is in the process is that the AMA will reach out to its members to see how many members want to sign on. We want to have a minimum of 500 members signing on so that we can implement the program, and it will start in the new budget year, which is April 1st of 2025.
And I'm wondering if you can explain the relationship between wait times to access panels, because I mean I don't know what the average panel is right now, but if doctors are being incentivized to take on more patients, won't that mean each patient will have to wait longer to see their doctor?
Not necessarily. We do have a number of physicians right now that have smaller panel sizes that they could, with this added incentive, take on more patients. We can also attract more family physicians to the province. We have seen that number grow, pardon me. Just in the last year, we've had 262 more family physicians and rural generalists enter into the province and set up practice, or at least register to practice with the AMA. We'd like to see that number grow for sure. We also want our family resident students to look at this as an attractive opportunity as well. We are providing a bursary program to medical resident students who would have a return of service if they want to work in a rural remote location, because that's where we see the greatest need. But with the tremendous growth, because Alberta is such an attractive province to come to, we've had over 400,000 people move to Alberta, I'd say, in the last couple of years. And so we need to make sure that we have a continual increase in our number of family physicians and rural generalists, and that they want to stay here. The ones that we have, we want to keep them here, and the ones that want to come in, we want to make it easier. We've worked with the College of Physicians and Surgeons to streamline our processes, and I can get into that, but that's a little longer discussion. But we're doing a multi-pronged approach to make sure that we stabilize the clinics and the physicians that we have currently, and also expand and get more interested in coming, and also young medical residents, that they would look at this as a really viable option to practice family medicine, because it's a great there's a great need, and it's a great lifestyle as well to be able to watch someone grow from a young child into adulthood and have that same family physician look after them. So I know that's what Albertans want, and I also know that many family physicians want to do that as well. Sure. Yeah, absolutely.
It did take us some time to sort through the number of patients on a panel that would be reasonable. And you can just understand the difference about why it's so important for us to incentivize patient panel growth and incentivize doctors to come back into this system if you take the opposite to the extreme. So if we incentivize smaller panels, because we were applying this model to 200 patient panels, we have 5 million or approaching 5 million people in Alberta, we'd need 25,000 doctors to make sure everyone had a family physician. On the other end, in the past, it was not unheard of that a doctor would have 1,000 patients. And if you had 1,000 patients per doctor, you'd only need 5,000 doctors. When I first started this conversation with the AMA, one of the things that they told me is that I believe, and I'm sure Doc will correct me if the numbers I'm saying need to be updated, but at the time they have on their roster 5,500 doctors out of about 11,700, 5,500 that are considered primary care practitioners, but only 2,500 of them have a practice. So you can see what we're trying to do here is that what do doctors do? Well, they work in hospital. That's another option. That's part of the reason we want to create the balance. So if we can get doctors who will have half of their time spent with patients and maybe another portion of their time in hospital, that's a good model for them. If we have doctors who are slightly below 500, giving them a pathway to come up to 500 so we can get more doctors on the roster. And docs who have left the primary care field altogether, giving them a reason to restart a family practice. Because I think just to understand how difficult it would be with the smaller patient panels. I don't know how long it would take us to go from 11,700 doctors up to 25,000 for primary care, and then we've got nothing left over for all the specialties. So that's the challenge that we're trying to address, is just have a look at the total number of patients that we now have to find doctors for, knowing that our objective is that every single person becomes attached to a family practitioner, and you'll see why it took a little bit of time for us to come up with a number that we think is going to achieve both of our objectives. Did you want to say anything?
Thank you. And looks like we have time for just one last question. Operator, could you put through our next caller, please?
Your next question comes from Dennis Kovtun of CBC Fort McMurray. Your line is already open.
My question is about how this new proposed physician compensation model is going to affect the access to family physicians in primary health care here in northern Alberta. So physicians both in the Peace region and in Wood Buffalo are quite exhausted, and the patients are frustrated as well with the issues of accessing family physicians here. So what effect is this new proposed model going to have?
So this new proposed model is certainly going to hopefully benefit the vast majority of physicians who want to practice comprehensive care. We probably need to make some tweaks for rural, because those physicians in particular do work, often 50% of their time in the hospital and 50% of their time in the clinic. So we may need to sort of see how this goes over the next little while, and may need to make a few adjustments for rural. It's important to know that this is just the start, right? And so one of our AMA staff told me this week that British Columbia is on version 19 of their manual for their, what they call their LFP. So, we're going to start this, and then, we're going to do like a quality assurance project, right? And assess it and see what we need to tweak as it moves forward.
I'll give an example of one thing that I hope happens, and it's going to be up to the innovation of each doctor to figure out the best composition of their care team. But I was down south at an event, and I met a doc who I believe was from Milk River, a podiatrist, and he said, you would be able to save $400 million in the healthcare system if we could just do better management of foot care of seniors who have diabetes. Because if you end up with a cut that becomes infected and then septic, it can result in hospitalization, it can result in amputation, it can result in death. But there isn't really a way to compensate a doctor to cut toenails on a weekly basis. But a doctor in a joint practice like that might be able to have a personal care assistant who would be able to make sure that somebody with diabetes was keeping up with those kinds of preventative measures so that it doesn't become acute. That's kind of the missing piece that I think we had when we were looking at chronic conditions. It's the one that is the most, maybe the one that was most tangible for me to be able to describe. But it could well be that there are other examples. I'll give you another one. My brother had a frozen arm and couldn't lift his arm for 2 years. He went to a physiotherapist and a laser specialist, and now he can lift his arm again. The other option would have been surgery. So I don't want to prejudge what these team models are going to look like. I think that it's going to unleash a bunch of innovation, which is what we want to do. And I think it's going to allow for the whole range of health professionals to be able to be built into team practice. And ultimately, what you'd like to see is that doctors will have time for both. They'll have time to be able to work in hospital as well as see the most acute patients, but then also have a team practice so that we can manage the chronic conditions. That's what we're trying to achieve. And I don't know if I'll turn it over to Adriana because she may have some more examples.
Thank you, Premier. The only thing I would add is that we will continue to have additional enhancements for rural remote locations. So this program is really geared to making sure that we are competitive with other provinces, that we're addressing all those areas where there were gaps in the fee-for-service, et cetera. But also we recognize that rural remote locations need additional attention, and that's why we also have a rural health strategy, and we have additional income compensation for rural remote locations and those doctors there. It's really enhancing that team aspect, as the Premier said, that we're looking to see. There isn't a silver bullet, so we have to do everything we can. It's also working with the College of Physicians and Surgeons to streamline their processes so that we can get international medical graduates here that want to practice quicker. They can go through the assessment process quicker and get into the workforce. In March, working with the College of Physicians and Surgeons, we were able to streamline the process so it wasn't just Alberta Health Services that could sponsor a international medically trained physician. It could also be a clinic, it could be a municipality. So it's taking a multi-pronged approach at dealing with these issues, knowing that we're going to have iterative processes, we're going to have to tweak things as we go along, and we have to be nimble and do that quickly. So hopefully that answers some of your question, but it's very complex. We have to do as much as we can to address these complex issues.
And did you have a follow-up?
Thank you. No, I don't. Thank you very much.
Perfect. That's all the time we have today. Thanks, everybody.
Thank you.